we have a very persistent member in our group. Her name is Jo Smith. When we discovered Dr. Blau's book, we decided, and she had read it, she said this would make a wonderful program, and we tried to locate Dr. Blau. Well, as many of you know, Dr. Blau's name is not exactly one of a kind. And at first we were in contact with the wrong Dr. Blau, but she persisted, and ultimately we got to the right Dr. Blau. And we invited him, and he was very gracious and agreed to come and speak to us. The name of his book is How to Get Out of the Hospital Alive. And many of you know who are in League, we have been working very hard to address the problem of people not knowing how to respond, what to do, how to inform themselves in terms of medical issues these days. And we're trying to find, it started really because people started talking about their negative experiences regarding medical issues. And everybody had a story to tell, and we decided, wouldn't it be nice if we took all of these stories and learned something from them, and this way we could help ourselves and help our community. So having Dr. Blau here is it in terms of our special project. And I want to tell you, take a few minutes to speak about his background. He graduated from Albert Einstein, a City College grad, by the way, my husband who, and many others, Phi Beta Kappa. His medical degree from Albert Einstein. He completed his internship and residency at Montefiore. His residency was in internal medicine. He did a fellowship at Albert Einstein in rheumatology. He is an attending physician and consultant in rheumatology at numerous hospitals and is clinical professor of medicine at SUNY Stony Brook. He has been in private practice in Massapequa for 35 years. In addition, he has written 8 books, published 50 original scientific articles, addressed the New York State Commission on Hospital Infections and Errors, and appeared on many TV programs. Dr. Blau wrote this book after a near-death experience in a hospital. His aim is to encourage patients to become empowered by questioning and becoming informed. And now I present Dr. Blau. Oh, questions and answers. I left the little index cards around. If anyone needs them, please raise your hands. After Dr. Blau's presentation, the floor will be open to questions and answers. Also, Dr. Blau is being videotaped, in case you're wondering what's cooking back there.
What good luck to have 2 Marjories introduce you. You really don't. By the way, thank you for those very, very nice words. I'm glad I brought my wife along to hear them. My mother, if she were here, would have believed them. How many of you out there know that there are 180,000 deaths per year as a result of medical mistakes? You all know? So you come and speak. Let me put that in its perspective for you. During Vietnam, we lost 44,000 troops. The death rate from cancer of the breast, cancer of the colon, cancer of the lung, does not come close to 180,000 per year. So we lose more people per year by medical mistakes than from disease and from some of the big wars. I want to tell you how it was almost, at least 10 years ago, 180,001. I almost died, and I'd like to tell you about my experience and tell you why and how my experience made me write a book. and what the purpose of the book was and is and will continue to be. I am, as you heard, hard to find because I have such a unique name named Blau. And I've been practicing rheumatology on the South Shore of Long Island now for some 30 years. I have, and by the way, I recognize some patients in the audience, and I say hello to them. One in particular said, "I haven't seen you in 30 years," which means I either did a good job or a bad job. In any event, I say hello to my patients. I greet you and say, welcome. Exactly, January 17th, 1994. Does anybody know what happened on January 17th, 1994? January 17th, 1994 was the day of the Northridge earthquake. Northridge is out in California. The earthquake was 6.4, which was humongous. Unfortunately, my 6-week-old granddaughter lived 10 miles from the epicenter. I got up in the morning and did my usual, I hadn't heard about this yet, but I got up in the morning and did my usual workout. I was hardly a jock. I was, as a matter of fact, my granddaughter Ashley would call me a wimp, but I still did my 20 minutes of exercise, came up, showered, and put on the TV set and heard about Northridge. When I heard about Northridge, I developed what I thought was indigestion, which did not respond to Tums. I thought then that it would probably go away, and I had worked out too hard that morning. Shortly thereafter, I developed pain in my left wrist. As a matter of fact, the pain in the left wrist, if I was not a rheumatologist, I would have thought that I had sprained my wrist. The pain in my left wrist lasted for a total of 20 minutes. I suspected, because there was no reason for me suddenly to have pain in my left wrist, that this indeed was what physicians call referred pain. In other words, pain from my heart that was being felt, and by the way, and it could be felt anywhere. It could be felt in your wrist, it could be felt in your tooth. The manifestations of an acute heart attack could easily be painful tooth. Mine was a painful wrist. I called my partner, who took me to a hospital that we used. We saw the cardiologist who we used, and it was suggested that I have an angioplasty. Now, I'll just tell you that an angioplasty is a procedure in which a tube that is surrounded by a balloon is passed through your artery to the blocked part of the artery that goes to the heart that's blocked. The blockage is always in an artery called the left anterior descending. I mention that to you because that artery is called the artery of death. When that artery occludes, you die, or at least that's what I was told. My left anterior descending was 90% occluded, and I was told by my cardiologist that I needed this procedure, an angioplasty, where they're going to pass this catheter surrounded by a balloon up to the blocked artery. Let me tell you that doctors, first of all, name catheters. Okay, this thing they were passing up through my artery is indeed a catheter. Most of you know what a Foley catheter is. That's a catheter for the bladder. There's a Swan-Ganz catheter, which is a catheter they use in the heart. The catheter they used on me should have been called the Hindenburg because it exploded. It exploded in my coronary artery. And the physician doing the test came over to me and said, and I can see his face now, I've put a rent in your coronary artery. Now, I wasn't sure then whether that was good or bad. I mean, I thought perhaps the rent was an extra piece of vascular tissue that would ultimately help me. The next question that I asked the cardiologist resolved whether a rent was good or bad. I asked the seemingly innocuous question, why did you do that? And then I knew that it wasn't good because he said, I didn't mean to. It was an error. You need and these were his words to me. By the way, I was still anesthetized. I was groggy. I was in a fog. He said to me, "You need a cardiac surgeon immediately." Now here I am, groggy, forced to make a decision. I tell you then, as now, I did not know the names nor the reputations of the cardiac surgeons at the hospital. I did then what I've been doing for 47 years of marriage. I said, call my wife. My wife came in and said, let's call cardiologist the cardiac surgeon that you want. I said, I don't know any of the cardiac surgeons. And I said, let's call the chief of the service. Now, by the way, so far, I have made 5 mistakes in everything that happened, and I'll tell you about the mistakes later. This was the 5th. The mistake I made was to call the chief of service, because let me tell you this, having been a chief of rheumatology for 23 years, a person is a chief because the chief does a great deal of administrative work. He ain't cutting, especially a surgeon. He's not doing surgery. As a matter of fact, when my wife came in and I said, get the chief, fortunately for me, the chief was doing a case. And my wife did what ultimately was done 5 years later, was published 5 years later, by Dr. Novella, the Commissioner of Health. My wife looked on the operating room board and saw who was doing the most surgery. And she said, let's get the guy who's done the most surgery because he's the most experienced. We did. He did the surgery. It ultimately was shown by Dr. Novella that the best cardiac surgeons are the ones who do the most surgery. As a matter of fact, what she did, I was kind of hoping she was going to be in this audience, if you want to know the truth, because I always wanted to meet her. But what she did, in essence, was she compared mortality, namely how many people die, with the number of procedures done. And immediately she discovered that if a doctor or an institution does less than 300 per year, that the mortality is enormous. Ultimately, years after I got out of the hospital, and we'll finish that story in a moment, it was established that certain hospitals had good mortalities. By good mortalities, I mean the patient was in good hands. And some hospitals had terrible mortalities. Now, I'm just going to tell you the best and the worst. And by the way, and this was 5 years ago, and it changes each year. And by the way, any of you here can find out who the best and who the worst are. Let me tell you that 5 years ago, when the statistics first appeared by the way, in Newsday, I might add, the hospital with the least mortality, that is the best hospital, was St. Francis. St. Francis had a mortality of less than 1%. Wait a minute, didn't we have a lady here? Yeah, you worked in St. Francis.
No, I was there.
You were at St. Francis. Now, the hospital that had the highest mortality, 9%, was Bellevue, NYU Bellevue. Now, stop and think about that for a minute. Let's just go over those figures, and let's see what that means. If St. Francis had a mortality of, let's say, 1 per 100, and Bellevue had a mortality of 9 per 100, that means that every 100 cases that Bellevue operated on, 8 would die unnecessarily if they were at St. Francis. Now, Bellevue does 3,000 cases a year. At least they did at that time. St. Francis does 6,000 cases per year. The mortality of a mere 8 per 100 multiplied by 3,000 comes to a difference of hundreds of cases per year as to simply dying. So who you pick is a terribly important thing, and you should prepare for that beforehand. You should not prepare for it, as I did, on the day of having wrist pain. Ultimately, let me get back to the story in the hospital. I'm admitted to the hospital. My wife wisely selects the man who has had the most experience. He does the case, and after 8 hours of surgery, I almost died. Did anybody here ever have a near-death experience? A near-death experience in which you see what Elizabeth Kubler-Ross calls the white light? Anybody? Yes. Okay. If any of you, and I won't ask this question, if any of you ever had bypass surgery, you had this experience. And let me tell you what the experience is. And as a matter of fact, you can ask this lady in the front because she had it. What happens is that for a brief instant, and I'll tell you exactly when it happens during cardiac surgery or when you, in quotes, die. When your heart stops, unless it's revived again, unless you're shocked again now with a defibrillator, unless you're put on bypass as I was in surgery, for a brief moment, as brief as a few seconds, you are dead. There's nothing going to you. Your heart has been stopped with potassium chloride, and a bypass system is inserted very rapidly into your aorta and into the great veins that return the blood. Now, it's during those few seconds. By the way, the longer that time is, the greater the likelihood is that you're going to not survive. During that time period, what happened to me, and what Elizabeth Kubler-Ross describes, is the greatest feeling of serenity I've ever had. There was no pain. There was no aggravation. There was such bliss that I'm happy it only lasted for a few seconds, because otherwise I wouldn't be here to talk to you about it. But it was a feeling that could only occur because of the secretion of massive doses of things called endorphins. So I sort of have a little bit of good news for all of us, because all of us are going to die, we all know that. When that moment comes, by whatever mechanism, there is a tremendous outpouring of these hormones, these opiate-like substances that we make ourselves. They're secreted in small amounts during exercise. They're excreted in small amounts during sex. They're excreted in small amounts during laughter. And they're excreted in huge amounts right before you die. Now, I'm recommending, of course, the first three and not the last. I had that experience. I awoke in the recovery room, which was a darkened room, and all I can remember is shaking chills. I had shaking chills, and the surgeon cardiac surgeons are marvelous human beings. They are interested in but one thing. The heart is functioning and the kidneys are filtering, then you're okay. And the surgeon came by, felt my pulse, found out everything was going well, and walked away. The anesthesiologist, on the other hand, told my wife that my shaking was a manifestation of the anesthesia. My wife said that her husband never moved like that in his life, and that it must be something else, and she said it was an infection. And she knew, having been married to me then 37 years, that kind of shaking that I had occurred only when I had an infection. She insisted that an infectious disease specialist, this was 9 o'clock at night, come down to see me. Against the protests of the anesthesiologist, a physician, Sal Scoma, came and said he has an infection and started me on antibiotics. The next morning, the tip of the catheter that was still in my heart grew out Staphylococcus. I was admitted to the ward on huge doses of intravenous antibiotics, which, by the way, I stayed on for a total of 6 weeks. I stayed on them for 6 weeks, and what happened during the 6 weeks is that my arms literally looked like salamis. Not Italian salamis, kosher Jewish salamis, fat and succulent and purple and red. I couldn't bend my arms because of the phlebitis that I had in it. At that time, my advocate, that's my wife, noticed that I was getting stuck. I was having venipunctures 6, 7, 8 times a day. She consolidated the venipunctures. Instead of, there's a difference, as we have some nurses in the audience, you know the difference between QID and Q6H. That means that you get, if you order at Q6H, you get it at 8 o'clock, 2 o'clock, 8 o'clock, and at 4 o'clock. If you order it 4 times a day, you get it at a different time. The problem was that each doctor was not communicating with the other doctor. resulting in the fact that my arms, when I came out of the hospital, I couldn't use them for months. I couldn't bend my arms for months because of the phlebitis. There was talk of putting a port in because of all of the venipunctions that I had. I managed to survive the infection, even though that was the worst winter on record. It was 94. By the way, when I drove over here today, it started to snow. I said, it's God telling me, remember what happened 10 years ago. I'm sorry, did you miss the front? Did you miss the beginning? Okay. I'm Blau, she couldn't find Blau, so a different Blau, Stony Brook. Now, we're at the section now where I am coming out of the recovery room, and I've developed phlebitis in both of my arms. But, by the way, the danger with phlebitis is, of course, clots. The clots go off to my lung. It was my advocate, and I will tell you later, and as a matter of fact, I spoke to Mrs. Smith before the talk. Mrs. Smith was Mr. Smith's advocate before he died. And she'll tell you that if it wasn't for her, that he would not have lasted as long as he did. And the same thing happened with me. If it weren't for my advocate, and one of the things I'm going to recommend and advise you all to have is an advocate. Someone, and you can make the deal now, you can make the deal with people in the audience, someone who is going to look after you when you get into the hospital. And it's much easier than you think. You're saying to yourself, what do I know if a doctor writes an order whether it's right or not? You can. There is a way of knowing if it's right. It's simply a matter of asking the doctor, verifying that the dose has been given, and being sure that whatever it was that was the doctor's intention is indeed carried out. The rest of the story is my taking a year off from work. By the way, I have patients now who had angiograms and bypasses who were out of work for 4 days. I was out for a year, attesting to the severity of the illness, that it took me almost a year to recover. Probably the most important thing in my recovery weighed 10 pounds. That was my granddaughter. My daughter had surprisingly I was doing poorly. I couldn't walk. I had to walk with an IV in me, and I used the pole for pressures. That's how weak I was. They were very concerned because I couldn't walk from here to across the room all of the time that I was in the hospital. One day, magically, my little angel appeared from California. I mean, I had no idea. I didn't even want my wife to call my daughter, but she did. My daughter came in. Again, okay, where are we now? We're back in the emergency room. Okay. Rheumatology, Long Island. No. Can you hear me now? Okay. Here I am now, almost dying. Did you miss that part? Okay, I'm almost dying. I can't walk across the room. I've put on, in fluid, 25 pounds, even though I have not eaten very much. I have put on 25 pounds on cruises, but I've never put on 25 pounds, in a few days. The reason I put on 25 pounds is I was in what's called congestive heart failure. I was in congestive heart failure and couldn't walk across the room. Everybody thought, particularly me, that I was going to die. I thought that this was the end. Now comes the part with my granddaughter, Ashley, who at the time is 6 weeks old. And my daughter literally snuck into the hospital, this little package, who I kissed, hugged, smelled her dirty diaper, and suddenly was regenerated. I was able to walk. It was the baby who made me better. It was just seeing that baby. It was now time on the day before my discharge for the IV to be removed. I had been, remember, on a pole and IVs for all of my hospital stay. And the nurse, and by the way, certainly this is not an indictment of the nursing profession, but the nurse who was told to remove the catheter from my arm had spent her entire career on an oncology service. In on an oncology service, you remove a catheter by pushing in the syringe first and then removing it. And the reason you do that is because there's residual chemotherapy in the line, and you want to push it in and give it to the patient. You don't do that to a patient who has just had a heart attack. By the way, I neglected to mention that what they had admitted me for, namely to prevent this heart attack, I had already had. Between having the between having the coronary artery torn and the delay in getting the surgery, I had already had the heart attack. In any event, the nurse pushed in instead of pulling out. That caused a clot to go into my lungs. I developed an arrhythmia called atrial fibrillation. It was on the day before my scheduled discharge. It was the angriest day of my entire life. It was the angriest day because I knew what would have to be done. I knew they would have to shock me to return a normal rhythm to my heart. Fortunately, a little digitalis went a long way. I was converted, not religiously, but converted to regular sinus rhythm within a few hours and left 2 days later. When I came home, as I told you, it took me a year to recover. I decided that I would in a scientific way, because after all, my professional career has been spent teaching and taking care of patients. The teaching part of it and the taking care of the patients really stems from a basis of scientific information, so that if I want to know how to treat your arthritis when you've just given birth, I have to know what's present in the literature. I did the very same thing with my co-writer. By the way, I don't want you to think that I wrote this book by myself, because even though I did write 8 books, the 8 books are all scientific. They're all, except for this one, they're all in my area of specialties, which is primarily lupus. So that the books that were written were on the basis of a scientific exploration of what was going on. And so was this book. In this book, and this was the very first book in which we wrote, Elaine Schinberg and myself, that 180,000 people die every year because of hospital errors. I was severely criticized for that statement. I had an open debate on Channel 7 with the president of the AMA, and her contention was, in quotes, "Hospitals are safe places." She certainly wasn't aware of the figures that we had dug up. As a result of the book, as was mentioned before at the gracious introduction, as a result of the book, what happened was that I was asked to testify in the New York State Senate Committee on Hospital Infections. As a result of that, and anybody familiar with Senator Roy Goodman? Roy Goodman, that's right, he just got a new job. He's now taking care of UN funds for New York, Connecticut, and Massachusetts. Roy Goodman asked me to testify to open Senate hearings about what had happened. As a result, by the way, I don't want you to think for a moment that I think that it was because of myself or my book. I also testified with a Nobel laureate from Rockefeller Center. As a result of that testimony, laboratories have been opened up that will immediately, I'm talking about in Long Island, I'm talking about now, I'm talking about they're working now. Laboratories were opened up that will immediately identify the strain of Staphylococcus that's present and see if it's epidemic. Now let's get back to the epidemic part. When I got my infection, I was immediately put into a room with a man who had a tube in his chest and pus was being collected. I didn't think that this was a good idea. I told the surgeon who had done the case he had no problems in switching me to another room. Unfortunately, in the other room was a man with an osteomyelitis of his clavicle and a port. So again, I was faced with infection. And on the floor was a patient who was unfortunately dying of a disease that has an almost 100% mortality that I had never heard of before. The disease, and you'll hear about it, you hear about it more now, it's called MRSA, M-R-S-A, methicillin sensitive, methicillin Staph aureus that's resistant to methicillin. As a result of MRSA, which means that there's an organism that can't be killed by any antibiotic, these patients are the very first thing any hospital will do with a MRSA patient. And I promise you, at every hospital now, as we sit, every hospital in Long Island, every hospital in the country, there sits one or more MRSA patients. And I promise you that those patients are all sitting in private rooms. Why? Because the very first thing you do with an infection, what is it that you did with your kids when they were infected? Exactly, you isolated them. I mean, we've known that for 1,000 years. I'm a little bit flattered by the fact that some 6 months after I came out of the hospital, I was called by the federal government concerning planning of new VA hospitals. And they wanted to know if I had, they also had read my book. They wanted to know if I had any thoughts about how how government hospitals should be built, VA hospitals. And I said, I have 3 thoughts: a private room, a private room, and a private room. And that all hospitals should have private rooms. By the way, if any of you have ever been out to California, Cedars has them. There are places in New York where you can get them above and beyond your insurance coverage at exorbitant rates. But there are private rooms that exist. I would say to you, especially if you have an infection, beg, borrow, and steal and get into a private room. So as a result of the book, as a result of my testimony to the Senate, a few good things have happened. The few good things is that soon there'll be a new hospital out in Northport. It's going to have single rooms. The second good thing is that there's a lab that's situated in Long Island that will immediately trace epidemics. Let me tell you a little bit about an epidemic. There are epidemics going on in every hospital, particularly in pediatrics. I mean, these kids have infectious disease that go from patient to patient very, very rapidly. It's the best thing. It's too bad that Mr. Walsh is not here, because as you all know, he's a hospital administrator, was a hospital administrator. There you are. As he can tell you, a hospital who has a rampant infection, an epidemic, if you will, has a boil on its behind. And that hospital has to get rid of that infection, or else the hospital will ultimately be closed down. The problem is reporting. Who is the one who's going to say, we're going to close down the pediatrics ward? Well, I can tell you that 5 years ago, there was a rampant infection in peds in a very prominent New York hospital. The hospital was never closed, the pediatric ward was never closed down. It took 2 years to find out that many children had unnecessarily been sick and died as a result of the fact that the pediatric ward was never closed down. So hospitals never want to close down pediatric wards or any other kind of a ward. I realized in retrospect that on my very ward, there were 6 patients who had the same infection that I had. And that's why I became an advocate of private rooms and a whole variety of other things. The whole variety of other things I would like you all to read in this book. Now let me tell you about this book. This book has been out now for about 4 or 5 years. I decided a long time ago that I was never going to get rich writing this book, but that what I wanted to do with this book is have the proceeds go to, if you will, the charity of my choice. The charity of my choice is a place that some of you may have heard of. It's called the Little Village School. The Little Village School is in Seaford. They just moved to these new, beautiful quarters. They've been run by 2 people who I invited here as my guests, Barbara and Carol, who are sitting in the back. And what I would like you all to do after I answer some of your questions is I would like to give you, the give is in quotation marks, I would like to give you a copy of this book, but I would like you to make out a check to the Little Village School. And the check is for as much as you want. The book in the store sold for $20. Give the Little Village School whatever you want. Thus far, having done this in the office, I think the largest check was $1,000. The smallest was $10. I hope that you'll be somewhere in the middle. And I have a box of books that I'm very happy to give and endorse over to any of you. I'm going to stop now for questions because I realize that I have been going on for a half hour. Are there any questions? Yes, ma'am. Well, let me tell you where the Little Village School is located. Carol Banks, Barbara, these are the CEOs of the Little Village School. The Little Village School is a school for developmental disabilities. And Carol, Barbara, can you say something about the Little Village School?
Hi, I'm sorry, I'm lost. I just want to tell you that we have been in existence for 34 years.
Carol, come up here. I have a mic that works. And if I know you for Little Village School, you'll run.
I'll be fine. Were you in Garden City?
Yes, yes. You see, I told you. It's easier to know about Little Village than about Blau. Come, please.
It's great, thank you. Hi, I'm Carol. This is surprise for us. We were invited to this luncheon. It was very nice to hear Shelley, and he gives us this gift. Little Village used to be in Garden City. We've been in existence for 34 years. And last year, we were able to purchase our own building in Seaford. We bought the old Massapequa General Hospital. We educate children who are infants to age 12 who all have developmental disabilities. And we see about 230 children in the school and about 140 at home. So we provide all the services that they need to make sure that they reach their potential. We work with families. We provide occupational therapy and physical therapy and speech therapy and, of course, education. And anybody who knows or can be touched by a family who has a developmentally disabled child, autism or physical therapy, cerebral palsy who needs physical therapy, knows the kind of work and efforts that people have to do. So we're there.
Do you have a website?
We do. It's littlevillage.org. littlevillage.school.org. Okay? And you're welcome to visit us.
Two questions. Where does your funding come from? And the second one is, are your students mainstreamed into the schools eventually?
We're hoping your funding is going to come from you.
All of our services are tuition free. Our funding comes from many places, mostly from State Education Department, school districts for children over 5, and Department of Health for children under 3. So it's a 12-month school year for the children, and parents don't pay any tuition. So we also use private donations, federal grants, local grants. We're always fundraising.
Well, sure. They're very heavy. I'll have someone carry.
Mainstream, yes, a very small proportion of our children are mainstream. Our children have a great deal of special needs. Many school districts do have programs within the school district now to bring back children. But as far as actual mainstream in a typical class, being that they are really able to deal with a typical educational program, most of the children get special ed help when they get out. Thank you.
Well, don't go away.
Thank you. That's so sweet. Give me a kiss. I can't. Thank you, everybody.
All right, now wait a minute. We have some questions here. First, are there any questions? I hesitated because of the videography to have people ask questions because perhaps they wouldn't want to be seen on television, on the videotape. But are there any other questions that I can answer before I read some people's questions who were submitted? Yes, ma'am.
If you have to sue a doctor, it's impossible to get a lawyer to represent you because doctors don't testify against
Oh,
you.
that's not true. That really isn't so. Let me tell you. That's just not so. I'm a consultant for a whole lot of people and a whole lot of organizations, and I do a fair amount of testifying against doctors. And it's not just me. I mean, anybody who has any credentials and wishes to do this is rewarded financially. I'm paid a ton of money to do this. And all the people who ask my opinion of is for the truth. Now, the truth sometimes is that no malpractice was committed. But the truth often is, and I have often, very often, equally decided that what the person, what the doctor, what the group did was indeed malpractice, and would and have and will testify against anyone who I think has truly done wrong. We don't, I know what you're implying, and it's not true. You're implying we protect ourselves.
A lot of doctors do.
Well, I'm sure that, I'm sure a lot of people protect each other. I would say the following to you. Dispel that notion that we're trying to save ourselves. We're really not. When a doctor won't, in quote, testify against another doctor, it probably is that he didn't think the other doctor did anything wrong. Other questions? Yes, sir.
Could you comment on the statistic you gave us earlier about best hospital, worst hospital?
Yeah. Thank you. That's such a good question.
In a certain context.
Yeah, no, that's really a good question.
I
Yeah.
know two people specifically who had needed heart surgery, were rejected by St. Francis as too risky.
Right.
And they went to Manhattan Hospital, and they survived.
Well, okay. Good question, and it brings up many points. The first point is, let's talk about the first point, because that's the point that I really want to emphasize, namely good hospitals, bad hospitals. You can find that out from the New York State Department of Health. They're presently, when Dr. Novella did this about 5 years ago, New York, California, and there's another state, were the only three that gave hospitals, if you will, report cards. Now 39 states do. So if you want to have heart surgery in Texas, all you need to do is call up the correct people there, name the Department of Health of Texas, whatever county you want to have it done, and say, I want to know your mortality. And not only will they give you the mortality of the hospital, but they'll give you the mortality of the doctor. And that's the most important thing. So that if you want to be operated by Dr. whatever, Department of Health, what's his mortality? How many deaths has he had? And by the way, the doctor himself will give it to you. Now, you brought up another very excellent point, namely that Bellevue had the 9% mortality because the worst operative cases were brought to Bellevue, and that's absolutely so. But still, that's a good point. Thank you. Yes, ma'am.
Can I ask you if Bellevue you're referring to is the old Bellevue that we
Yeah.
know, not University?
Not University Hospital. As a matter of fact, Bellevue is several hospitals. The one that had the worst mortality was the one we know, the old one. Not University Hospital. Not the. It's interesting. You know, it's kind of interesting. The staff at Bellevue and the staff at University Hospital are really mostly the same, except for the teaching part of Bellevue. Bellevue, of course, sees a much lower class of patients because there's a significant percentage of patients at Bellevue, just as at Nassau County Medical Center and all of the teaching hospitals, that a significant number of patients who don't have insurance, which means that they're poor, which means that they often are in poor health, physical health, and therefore a higher mortality would actually occur. And that's why what was implied by the question before was that the hard cases are being sent to Bellevue and not being done at St. Francis. And that may be absolutely true. It may be absolutely so that St. Francis is saying we only want to do, but I don't think so. You know why? Because St. Francis is doing 6,000 cases a year. It's hard for me to imagine that they're taking the bad ones and shipping them elsewhere. Now, I have some questions here, I think, on cars. Okay. Oh, yes, the 5 mistakes that I thank you. Okay, I made more than 5 mistakes. The first mistake I made is not to select the correct surgeon. I selected a surgeon on the basis of get me the chief of service. The second mistake I made is not to see what the mortality of the hospital was for cardiac surgery. Third mistake I made, my wife astutely picked it up, was that I was given simultaneously, I had orders written for both give fluids and give Lasix. Now Lasix is a diuretic that gets rid of fluid. To do those diametrically opposite maneuvers is absolutely ludicrous. And by the way, I was sleeping through most of this. So it was my wife who noticed this, and that's when I say to you, you should all have availability to the doctor's orders. And it was she who straightened it out. And how did she straighten it out? She went yet to a third doctor, my partner Jim Sullivan, and said, why should anybody be given fluids and be given Lasix at the same time? And he said, it doesn't make any sense to me. And he called both doctors and said, one of you guys is doing something wrong. And it was fixed. It was fixed. I think, I don't remember if the floors were stopped. They probably were stopped. Yes? What can be done to improve nursing care in hospitals? You know, I tell you, there's an advantage of being old. And I'll tell you what the advantage is. I have seen, having graduated from Einstein, when I went to Einstein there was mud. There was only Einstein and Ullman, which is the building next to it, for tuberculosis. There was not, as there is now, a nursing school. Since I left, everything has happened. I was in the 3rd class there. I mean, now they're graduating, I think they're the 40th class. No, more. Probably 3 years before me would have been 57. Yeah, probably they may be graduating their 45th class. You know what can be done to improve any kind of care, teaching care, nursing care, medical care? Pay them more. You pay them more. I mean, the reason that people, most people, not all people, most people are motivated is by money. If any of you out there have a job in which the salary could double by doing the very same thing, you'll leave and you'll go to the place with the higher money. I can improve the nursing system very easily. All I have to do is increase how much money they make. If you increase how much money they make, more people will want to do nursing. Yes. Everyone would like a private room in a hospital, but how does one pay for it? Prostitution? Drugs? Okay, yeah, it's a valid question, and unfortunately, you know, we have had some family illness, and we have had a private suite that cost a fortune a day. My main complaint to the people at the hospital was, why can't every patient have a private room? The answer is, there aren't enough private rooms. I mean, it's as simple as that. If you wish a private room now, in the hospital of your choice now, and there is no patient in there with MRSA, okay, methicillin-resistant Staph aureus, and you want to pay more than your hospital, you know, your hospital, or most of you, most of your coverages are not for private rooms, they're for semi-private rooms. If you want to pay more, you can get one. As a matter of fact, the next time any of you, unfortunately have to be hospitalized, say, I want a private room. How much more will it cost? Yes, ma'am.
My question really was, if you flipped it over.
Oh, wait a minute, I didn't flip it over yet.
Problem with
It says flip it over.
health insurance and the fact that they will not pay.
Oh, well, that's a separate, yeah. Okay, when you speak about health insurance, that's a pet topic of mine. I was, in the 60s, I was an advocate of Lyndon Johnson's Medicare. Every doctor was against it. I was for it. Right now, I don't know how many of you see your physician solely under insurance. I would guess most of you. And few of you have to pay what you had to pay in the 60s and the 70s. The bottom line of this is that a private room is a luxury now. It shouldn't be a luxury. If you're in LA and you have chest pain, tell them you want to go to Cedars-Sinai. They can't send you away, and they're going to put you into a private room. If you want to do the very same thing in New York, it'll cost you a fortune. How will insurance help that? I'll tell you. There are insurance policies that will pay for a private room. They will pay, now catch this, they will pay everything that you have that everybody else won't pay for. They will pay for a cane, they will pay for physical therapy, they will pay for an electric scooter, they will pay for a hearing aid, they will pay for everything. But let me tell you what their premium is. Their premium is 75% per year of what you want to be insured for. So let's say that you say, oh, well, I need some elective surgery. Oh, by the way, remind me to tell you about elective surgery and why you should never go in July. Elective surgery, let's say that you know that you're going to have $10,000 worth of above and beyond medical expenses. You can take out this plan. This plan will charge you $7,500 for the year. They will bill you monthly, If it should happen that in one of those months you should die, the insurance company will be happy, you will be unhappy, but you won't have to pay any more money. And if you have to, and if you live for the year and have whatever your expenses are, they'll reimburse you 75%. Any other? Yes, ma'am.
When someone goes into a hospital, is it kind of true that if they have a lot of visitors, they get more attention from the staff than if no one comes to visit the person?
No, that's not true. The question, I'm sorry, the question was, is it true that if a patient goes into the hospital and has a lot of visitors, that patient will get more attention from the staff than a patient who doesn't have a lot of visitors? No, that's just not true at all. In other words, visitors are a pain in the neck for the nursing staff. They're a pain in the neck, especially when you're in a two-bedroom for the other patient, and especially when the illnesses are not, if you will, evenly divided. I mean, for instance, to put in a two-bedroom a young patient with appendicitis and an older patient with a malignant disease is stupid. The more patients you have, it makes very little difference. And it makes very little difference, by the way, the care that you receive depending on who you are. As a matter of fact, I still am, how shall I put it, a chief of service. I was known, and still am, by most of the people at the hospital. And the care I got was certainly inferior. And you want to know something? It was almost nobody's fault. It was everybody's fault and nobody's fault. If you ask me, nobody asked me, did I sue the hospital? The answer is no. And the reason I didn't sue the hospital is two reasons. The first reason is that it was nobody's fault, but it was everybody's fault. And that's why I wrote this book. As a matter of fact, I really didn't get a chance to emphasize, by the way, there were 5 mistakes I made. I selected the wrong hospital. I selected the wrong doctor. I needed my advocate, my wife, to decide that I had an infection. I mean, I couldn't decide it. It was she who called the infectious disease expert. That should not have been. The 4th mistake that I made is just not knowing. I had no idea when the doctor who did the angioplasty on me said, I put a rent in your coronary artery. I actually thought it was good. I didn't know what the implications of that procedure were. The implications were that it has a mortality rate of 1 to 3%. Now, let me tell you a couple other things. I did not want to ask how many in the audience have had either stents or angioplasties or bypasses, but I'll tell you the following. And please verify this with your children and your grandchildren who are doctors. Ask them how many unnecessary stents, angioplasties, and bypasses are done. And you know what number you're going to come back with? 50%. So half of you in this audience, if I were to ask how many had bypasses, half of you who had them didn't have to have them.
What would they have done instead?
What? Get a second opinion. And if the second opinion, and by the way, and if you're uncomfortable, by the way, I mentioned in the book here about trust your instincts. Okay? If it's suggested that you have a procedure that has a mortality of 1 to 3%, find out what the alternatives are. You know what the alternatives to my surgery, to my angioplasty were? Patches, pills. I still would have been alive now 10 years later. I would have taken pills. I would not have faced that experience. There are always, almost always, alternatives for elective procedures. Mr. Walsh, as a matter of fact, I've been looking forward. I don't know. I know that you all know Mr. Walsh, but
I'm Mr. Brodsky. I know Mr. Walsh.
I thought you were Walsh.
No.
What happened to Walsh? Mr. Brodsky, excuse me.
CEO of Lincoln.
Excuse me. I say, excuse me.
This is a loaded question because, if you
What?
know, I have some hospital background.
Under the stress of sign this or else, as Jerry Lewis once said, he said that he had some chest pain and he went and he saw DeBakey. And DeBakey said, sign this but you need a double bypass. And Jerry Lewis said, can we get another opinion? He said, if you don't sign it, you're going to die. And that's exactly what happens. I mean, I don't know what's in an informed consent. We have patients in my office sign informed consents for a variety of things. The informed consents are drawn up by lawyers, they're signed by patients. I promise you that nobody knows what's in that informed consent. And when push comes to shove, i.e. malpractice, okay, it's going to be the lawyers that win. A lawyer in a room with a non-lawyer is like one man with a buzzsaw and the other man with nothing. But thank you for that question. Yes, ma'am. Two more questions, we're out of here.
I have a daughter who's a doctor, and she always says, stay out of the hospital.
Oh, she's so smart.
Because there's loads of infections in the hospital. But listening to you, I've got the feeling, stay away from doctors, because they can cause you a lot of problems. Now, you're going around talking the way you have been here. What is the reaction of other doctors to your message?
I'm glad you asked all of those questions. First of all, your daughter's right. Stay out of hospitals. Stay out of hospitals because of what's called nosocomial. That means hospital-acquired infections. Superbugs, that's what they are. They're superorganisms. MRSA, MRSA, is a superbug. Yes, stay out of the hospital. Stay out of the hospital because it's only in the it's mostly in the hospital that you're going to find these superbugs. My argument when you ask me how other doctors greeted my book, like everything else in life, my friends thought it was marvelous and my enemies thought it was terrible. When we discussed it on a point-by-point basis, for instance, one of the issues I make in this book is never go into a university hospital for an elective procedure in July. In other words, never go to Stony Brook. And why? Because the intern that you're going to see July was 2 weeks ago a medical student. And his resident, okay, was 2 weeks ago an intern. There is no substitute for experience. When you go into a teaching hospital, and I've been associated with a teaching hospital all of my life and still am. When you go into a teaching hospital, remember who it is who's coming and taking care of you. Yes, ma'am.
I have two sons who are surgeons, and they don't live near me because they want to live where they're 10 minutes from the hospitals where their patients are. And they work very long hours writing up reports so that the people who follow them will know exactly what to do. You haven't said anything about these very wonderful, dedicated, life-saving.
Do you think that me as a physician would not say that doctors are dedicated? Do you think that I believe that there are doctors? Of course. Of course. I mean, if you want to know what the most dedicated profession is, you guys pick it. Stockbroker, lawyer, insurance salesman, I'll go on. Car dealer, or doctor? You pick it. Yes, ma'am.
Yes, would you say the same things are true in terms of infection for this new trend in these outpatient ambulatory surgery facilities?
No, they're not. They're not because you're not kept there. In other words, the big problem with inpatient, nosocomial infections do not occur in an outpatient setting. They occur only in an inpatient setting. Let me read this last question. Are you going to ask me one? Okay, go ahead. Watch out. Okay. There are state laws to protect training surgeons from working too many hours. Thank you. As a matter of fact, a friend of mine was the designer of these laws. And as a matter of fact, he was my resident. However, the hospital administrator says, if you don't like the long hours, get out of the program. How to protect surgical residents. Well, you're right. I'm trying to remember the name of the legislation because he was my resident when I was an intern. You're right. No, Libby Zion was not. No, Libby Zion was a separate case. But thank you for bringing up Libby Zion for me. Does everybody know who Libby Zion was? Okay, so I'm not going to tell you who Libby Zion was. But that was not the 12-hour thing. A source of cheap labor are interns and residents. There's such a source of cheap labor. By the way, when I say cheap labor, I just want to give you a little example. When I was an intern, I was paid $80 a month. $80 a month. My rent was $87, so I was always behind. Now, the average house staff officer starts at $25,000 a year And if he becomes 3, 4, 5 years into a residency, he can make $40,000, $50,000 a year. So now it's still, if you will, cheaper labor. It's cheaper to hire a resident than to hire a practicing doctor. But the fact of the matter is, several years ago, probably Bert, I don't remember his last name, was the author of this legislation. And the legislation said you can't work more than 12 hours without a break. It really is. I promise you, wait a minute, we spoke before about the Joint, the Joint Commission, I promise you, when they come down to review a hospital, we'll take in, did you tell me you were on the Joint Commission? No.
No, Dr. Collins.
I promise you the Joint Commission, when they come down, will look at work at hours and things like that. I mean, that was put into effect. Certainly that, like, all new legislation doesn't work, the best because there are abuses of it, but still it works. That a doctor can't work more than 24 hours. I used to work 36 hours on and 12 off. So I would go into the hospital Monday morning, stay all of Monday. Tuesday, I would be off at 8 o'clock and I have to be back Wednesday morning. So I worked, I don't know, 100-some hours a week. Yes, did you want me to?
Yes, I wanted to ask a question, and it impacted on something you said that reminded me, because I had a friend some years back who was dreadfully ill, and you had said that one doctor was ordering Lasix, another doctor was ordering fluids, and what happened to her was that there was no one doctor, and usually it's the internist that puts things together. Many times patients go to have the cardiologist prescribe certain medication, the internist may prescribe, they may have some orthopedic problem, the orthopedist prescribe, they have all kinds of medications, and they end up with problems, as this friend of mine did, dreadful problems, because one medication really was countering another one, and nobody was looking at the total picture. And I always thought that the internist was the one who put everything together. But seemingly, that's not necessarily so, and that can be very frightening as well.
It's a very good point, and it's absolutely so. The internist should be, if you will, the captain of the ship. Unfortunately, as a matter of fact, unfortunately that doesn't happen all the time, that's number one. Number two is, in this era of sub-specialization, where not only are you a specialist in, I'm a board-certified internist, I'm also a board-certified rheumatologist. Also my sub-specialty is lupus. So in this era of sub-specialty, it's very common for each doctor to act independently without consulting another doctor. And often my Lasix and fluid overload, one undoes the other. You have to have a captain of the ship. You see, you have to know what you want. You have to know what's best for you. As she said, when she goes in, and she may be on, and by the way, the average person over the age of 50, you hear? The average person over the age of 50 takes 7 pills a day forever. So if you stop to think how many pills you take, everybody's nodding, everybody's taking more than the 7 pills.
Does it include vitamins too?
No, just medicines, just prescribed medication. Now, certainly there are drug interactions. As a matter of fact, part of the 180,000 deaths a year are as the result of drug interactions. I'll tell you just of yesterday's case. Yesterday's case is a young girl in my office who has a seizure disorder and is on an anti-seizure medication. And I know that if I give her, and she's also suffering from arthritis, I know if I give her a pain pill or an arthritis pill, her anti-seizure medicine will go to the sky. And she will probably pass out. It may happen when she's driving. It may happen when she's with her baby. And I refuse to give her other medications. When she went to another doctor, the other doctor said, let's give her some so-and-so. I told her the two shouldn't be given. Many doctors are not aware of drug-to-drug interactions. Those of you who use the big pharmacies, where you go in and you get a printout, do not use with those are great. Also, there's a book that's our Bible. For those of us who aren't too religious, it's called the PDR. Okay, I think I would recommend that we get it for nothing. They're about $60. I would suggest you all buy a PDR. And when you serve, for instance, as a patient's advocate, and the patient is allergic to penicillin, there's a whole list of other things that he's allergic to, including amoxicillin, staphylococcus, and all kinds of other medications that are in this same class. So I would say that must reading for you, even though it may be difficult, is the PDR. And if you happen to pick up the PDR, and the PDR says, if any of you are taking any of the SSRIs, that's Prozac, that's Zoloft, that you may get what's called delusional hyponatremia, which means your serum sodium can go down, which means you can have seizures as a result of this. I cannot begin to tell you how many patients and I'm not a psychiatrist, and I'm not an internist, how many patients I have seen now who have had this phenomenon occur to them. Namely, the mere institution of a Zoloft or Paxil-like drug. And the patient becomes, as some of you are in the front row, a little sleepy, a little tired, and then if you get a little more sleepy, a little more tired, you have a seizure, and then they don't know why and then you go to the hospital and your serum sodium is very, very low. So there are many side effects of medications that the only way you, and us, every doctor has a copy of the PDR in his office, and every doctor should unashamedly open it up. When you come into me and you tell me you're on a drug I never heard of, I say, hold on for a minute. I open up the PDR. The lady with the purple, the last question, and then we go. Physician's desk reference. Physician's desk reference.
I have a question.
Yes, ma'am.
You would like to actually address this, but what is
Go
the
ahead.
infection rate in emergency rooms?
It depends. I'm glad you reminded me about emergency rooms. Yeah, emergency rooms are, okay. Thank you. The highest rate, catch this for a minute, of assault, rape, murder, and robbery are in the parking room of emergency rooms. In the parking lot. The parking lot. In other words, when you drive up to any of the emergency rooms and there's a parking lot, it's not protected, it's isolated, and you have to go from there to wherever. That's where the highest rate of these things occur. The second thing that you should know about emergency rooms is that not all emergency rooms are really emergency rooms. If you go to an emergency room and the emergency room is not equipped for things like bypass surgery, for certain sophisticated neurologic procedures for impending strokes. When I say impending, I'm talking about you can now, the state of the art for this year, for 03, the state of the art in neurology is to ward off an impending stroke. But you have to do it within 2 hours. So all of us, myself included, should have, and I do, and I'm not going to tell you what it is, should have a hospital designated in your mind as what happens if all of a sudden I start with pins and needles in my arm and I can't move and my speech becomes a little bit garbled. Where should I go? If you go to the wrong emergency room, if you go to Massapequa General, if you go to the wrong emergency room, they're going to treat you as a stroke. You're not going to have the advantage of a certain type of therapy that is shown to reverse the stroke. So emergency rooms are a very, very important place. Oh, there's one other thing about emergency rooms I have to tell you. National census of all emergencies across the country. You're not going to believe this. 25% of the people sitting in the emergency room, waiting, are armed. Armed with guns, with knives. I personally, when I was a medical student, saw a doctor killed because some crazy patient on a litter, on a stretcher, just took out a knife and cut him in the liver. Emergency rooms are very dangerous places. By the way, I didn't answer your original question about what's the infectious rate in emergency rooms. As long as there's flow. I mean, you know what makes an infection? Stagnation. Stagnation, whether it's ass, whether it's sewage, whether it's food. Stagnation. In emergency rooms where, you may be seeing, especially a busy emergency room, 20, 30, 40, 50,000 visits a day, you're probably okay. Nosocomial infections have not been a source of problem for ER as they've been a source of problem for inpatients. Yes, ma'am. I just can't stop talking to you. Go ahead.
I want to recommend that you get this book
I
because
want-
it hasn't mentioned such things as why you should get to know the different kinds of staff that you're going to be dealing with, how to prevent a fall in the hospital, and a whole
Thank you.
host of other, and just very easy reading, and it's very written with humor also, but very important information that you can't possibly touch on.
Thank you. Thank you. You know, I'm glad that you said that. And by the way, the ladies in the back are waiting with books and a pen. So I would like you all to give, especially those of you who are, how shall I best put it? What's the expensive neighborhood in Great Neck?
Kings Point.
Kings Point. Those of you who live in Kings Point, please go first, all right? And it'll be in privacy. Nobody is going to see the check that you write. And let me assure you that it is for the very best purpose you can imagine. Let me tell you, those kids are sick 24/7.
And they'll be helping themselves out.
Exactly. Yes, ma'am, I got it. You're, yes.
I just want to make one statement.
Go ahead. As long as it sells books for little villages, okay. You do have a PDR, right? I know. I know.
So very
The question was that she has a PDR and it's difficult to refer to. You're right. Wait, she's in the middle of this one. Wait, otherwise we're gonna have her. You can. I promise you. I promise you. I'll let you in. But she's in the middle of a question. Do you want to interrupt her? Well,
very quickly.
I'll let you speak.
Suggest
Yes.
that I personally have found it very helpful to double check with the pharmacist
Yeah.
if there is any question about interaction. And that's all I want to say.
Well,
Double check with the pharmacist.
The pharmacist uses the computer because absolutely.
Whatever he uses.
Sure. I thought you were going to object to the PDR because it's my main objection. I can't see the letters; it's too small.
It's hard.
Yeah. Now I'm sorry, ma'am. You asked a question, and
Well, first of all, about the PDR.
Yes.
It is difficult to understand.
Right.
I would like to recommend, in addition, that you get the pill book, which is in paperback. It's in every bookstore. It's like a patient's PDR manual.
There are. We physicians use PDR. There are many volumes written for patients. The Harvard School of Pills. Yes, I'm sorry. Go ahead.
The second thing I wanted to say, since I've been hospitalized 4 times in less than 2 years, the most important thing that you said, if I can emphasize it and re-emphasize it, is having a member of the family, an advocate with you, because my oldest son was with me each time, and he understood what was happening, and when I was aware, he was able to explain it to me and talk to the doctors, and I cannot tell you how invaluable it is.
Absolutely. Thank you. Thank you for emphasizing the importance of the advocate. Ladies and gentlemen, I want you to line up with your checkbooks. Thank you very much, and we'll meet again.
Thank you so much.